We'll start with our Botox, and then we're going to go with our fillers. All right, so next. All right, we've all heard of botulinum toxin. Where does it come from? Clostridium botulinum. There's 7 serotypes, but the type A is going to be the most stable and the easiest to reproduce, and so that's what we use, okay? So the way that it works, I'm sure everybody here knows how Botox works, right? It works at the neuromuscular junction at the end plate. It prevents the ACH from being released. When it prevents the ACH from being released, you don't get the muscle spasm. All right, so that's what happens with that. So what's the timeline? The timeline, so a couple of things. There's 3 different type of neurotoxins that we have currently that's FDA approved in the US. There's another one that's coming out shortly from China, Korea, from Korea.
Evolus.
It's called Evolus. Maybe we should all buy stock now.
We should. It's going to get FDA approval by the end of the year, beginning of spring.
We should all buy together as a group.
Allergan stocks went down when they made that announcement, and their stocks surged.
Right.
And it'll be a game changer.
Yes.
How do you spell it?
EVOLUS.
It's already pre-mixed, so it's a liquid form, right?
Oh, wow.
Yeah, so it's not a dried, yeah. So Dysport, Xeomin, and Botox, those are the 3. This is a CME course, so botulinum toxin. We have abotulinum toxin and onabotulinum toxin. The difference is with the Xeomin and the Botox, you dilute it differently than you do. The units that are diluted are different than units that you have from the Dysport. All right, so we're going to go over how to reconstitute and how many units are actually being injected as you're injecting. The dispersion size of Botox and Xeomin is about a dime size. So if you can imagine, if you want to get the whole forehead treated, you're going to go about a dime width to get everything injected in that area. Okay. As far as Dysport, there's a little bit more dispersion. That could be good, could be bad. In areas like the forehead, having a little bit more dispersion is good. But if you're near the eyes and you don't want the lid ptosis, you may not want to inject, the Dysport, which actually disperses to about a nickel size versus a dime size. So let's look at the timeline. We know that Botox or botulinum injections are FDA approved for certain things, and there's a lot of things that are not FDA approved. So in 2002, glabellar lines, the 11 lines, the angry lines. We'll talk about that with the Proceras. 2004 for hyperhidrosis. 2012 for chronic migraines. In 2013 for the lateral cantharitis, which is the crow's feet, but it wasn't, and then obviously for us, overactive bladder was approved in 2015, but it wasn't until just recently, in 2017, was it actually approved for forehead lines. So even forehead lines, everybody was doing off-label, okay? So as you know, as injectors, we can certainly do things that are off-label, but these are the on-label cleared procedures. So next. Okay, so what are some of these off-label uses? Do you guys know what bunny lines are? If you kind of scrunch your nose like this, you get these little lines on the side here. So those are the bunny lines. Off-label uses for bruxism, okay, which is teeth clenching and even TMJ. The jelly roll, I actually have a patient, she was supposed to come today, but she said to me one side of one eye looked smaller than the other eye, and she could only see this in pictures. And it was so subtle because she said, oh, my lid actually comes down a little bit more. But it wasn't her lid. It was actually her little jelly roll. She actually had, when you see blepharospasm, things like that, she had a little jelly roll in there, and it was the bottom that came up, the bottom lid that came up, that made her eye look a little bit asymmetrical. The nasal tip lift, so we all have this muscle here underneath the nasalis here that depresses everything, and some patients want that nasal tip flare. Gummy smile, the lip lift or the lip flip, which I really like to do, that for those patients who have really big smiles and you can see a lot of their gums, you can actually put 1 to 2 units here, 1 to 2 units here, and we'll go over exactly where that is. The lip flip is great. I love it. It's great for the millennials. Certainly they can have some oral incompetence right afterwards, which is a funny way of saying, like, they may not be able to whistle, they can't purse their lips as much, maybe kissing is a little bit off, but they do love it because it actually shows more of the inner lip line, and it gives you that nice full look with just a couple of units of Botox without actually having to put fillers in their lip. The vertical lip lines, smoker lines, will go over. Marionette lines, which are these lines down here. You can also do a little bit of Botox in there. Dimple chin. Dimple chin for me is something that I like to do, and I'll tell you why. Often there's a little extra Botox and you don't know where to put it. You don't want to put too much in the forehead. I always tell them, make that little face and scrunch up your chin to make that dimple chin. It looks like a peach pit. I think I injected myself, so I don't know if I can do it. But you do a couple there, and what it does is kind of lowers everything, gives you a nice little jawline, and then when you smile in pictures, that doesn't come up. Platysmal lines, the Nefertiti neck lift, these are all muscles that, when you really make that face, you get all these bands, and people don't like how that looks, so that really relaxes it and gives you a nice little lift here. Masseter hypertrophy, pretty much for bruxism as well, and parotid hypertrophy. We actually have a gentleman coming today who has asymmetric masseter hypertrophy who wants me to inject him. We'll examine him. We'll see if it's parotid in nature as well. But he had an MRI that didn't show that. So next. Okay, so I don't have a pointer, but where can neurotoxins be used? The most common places are going to be your frown lines, the 11 lines here. That's the most common thing that people ask me. The second most common thing is the forehead lines. Okay, so in order of common, people always ask me about the frown lines, the 11 lines, the forehead creases. The brow lift, very, very popular in millennials. Millennials have increased by 40% in services that they get from aesthetic providers, and so they're a big. So that's a big that's a big group of people that you want to kind of cater to. And Instagram, I will say, is probably the best way to reach these patients. Some people talk about Snapchat. I think those are the younger, and maybe lips, like the Kylie Jenner population. But I think for the brow lift, I think everybody likes to look more rejuvenated with just one unit underneath each eyebrow. The bunny lines over here, crow's feet. So masseter injection is so huge. I had my own masseters injected. I re-injected them 2 days ago, but it really does slim the face. Now, is there a chance where you're slimming the face and things kind of droop a little bit more? It's a possibility. So make sure when you feel for their masseters, you make sure they don't have a lot of laxity, because they could potentially kind of bring down a little bit more of the face, and you don't want kind of that, that dragging, that sagging of the mid-face. And we could talk about jaw recontouring and lifting that up, and then threads in the future. Lip lines we can do with Botox. Those are the smoker lines, the gummy smile, the jowls, the chin wrinkles, and the neck cord lines. Okay, so go to the next one. So before we inject any neurotoxin, you have to get an H&P. Okay, I was at a charity event recently where the neurologist was like, "Oh, I never do an H&P." It could only protect yourself to do an H&P, because if they have, God forbid, myasthenia gravis or Eaton-Lambert or something where you're unaware. Okay, there was a recent litigation suit where a med spa in Oklahoma was sued because they injected Restylane and the patient had some scarring. Now, I don't know much about that, but if you have in your consent form possible scarring, possible granuloma formation, possible, asymmetry, lumpiness, as long as that is in your consent, you should be covered. All right. The good news is that a lot of these things are reversible, and when I say reversible, if you're losing hyaluronic acid, and they're not permanent. So that's the good thing. Prior allergic reaction is important. That's very rare to have an allergic reaction to botulinum. What we typically see, and it's very rare, is someone will say, I've been getting it for years, and then the last time I got it, I felt like it didn't work, right? So that's when you switch to something else like Dysport or Xeomin, right? Because it's more purified, less protein, and so forth. Active infection and inflammation, I probably would not inject if they have active inflammation over the area. So these are all kind of very intuitive things. Keloid scars, so that, I don't know if that's an actual contraindication or if that's a relative, it's absolute versus relative contraindication, because keloids are very, although they can be common, after incisions and things like that, if you're just using a needle and in the face, the keloid keloid production is very, it's very rare. But that being said, you want to ask the patient if they have a history of keloids. That may not be, you may not want to inject that person as one of your first time patients. Pregnancy or breastfeeding. Now, there are certainly no studies, because no one's going to do studies on pregnant or lactating women to show the adverse effects, but from a legal standpoint, it's just best if you stay away from it. Now, do you have to get a urine HCG on every patient that comes in? No. On our consent forms, and after this course, we're going to send you for something, some of you already have our consent forms already. It just asks, are you potentially pregnant or are you lactating? And if you say no, that will cover you. Okay, so that's very important.
Every time they come in for an injection, they have to sign?
I do. It would only protect you if you do it every single time. Okay. Yeah. Relative contraindications, we talked a little bit about myasthenia gravis, or anything, any kind of autoimmune disorder where you're going to have issues, with your neuromuscular problems. Avoid medications that decrease neuromuscular transmission, so aminoglycosides, penicillamine, quinine, and calcium channel blockers. These are all relative contraindications. It doesn't mean you can't do it. You just have to know what medications these patients are on. Next one. All right, so remember, next one. Is it not going? Okay. Remember your Netter's anatomy from a long time ago for most of us. So these are the muscles of facial expression, and these are the most important muscles that you're going to need to know. All right. When you understand the insertion and the origin of these muscles and how they work, you will understand what will happen if you paralyze those muscles. Makes sense, right? So occipital frontalis is the big muscle that goes from the occipital all the way to the frontalis. The frontalis belly actually splits most of the time. Now, everyone is different. There is no cookie cutter way of injecting patients. We can give you a template, but everyone's different. If you're unsure, you have them make faces, and you actually put your hands and touch the patient. Scrunch up your forehead. Look surprised for me. See where the muscle belly is most prominent, and those are the areas that you want to inject, okay? So what does the frontalis muscle do? It actually scrunches up your face and causes those lateral rhytids, right? So those horizontal lines. That's what that does. It causes those lines. It foreshortens the forehead. It's a brow lifter, right? It's really the only muscle that actually lifts all this. So what does that mean? That means when you're injecting, you're going to get a little bit of a drop. You cannot, most of the time, you don't just inject the frontalis without injecting the glabella area, because they oppose each other. If you just injected this area, what are they going to have? They're going to have a brow droop, and they don't want that, right? If you do the glabella and you do a little bit of the frontalis, that's when you have that nice kind of counteracting look that we want. With the exception of young millennials, when someone says, I have one line on my forehead that I just want to get rid of, I always try to do a little bit of injection here because I don't want that to drop. The Spock look that you mentioned, right? The Spock look is when you inject the glabella area and you inject the forehead, but you don't inject enough right over the area of spocking. Some people like the Spock look. Yep. They do. I will say, yes.
Some actually want it and they ask for it.
Yeah. So as an Asian person, I always want my eyes to look bigger, right? I don't mind the Spock look at all. Obviously, mine doesn't Spock too much. But as you can see, as a look surprise, there's a little bit of spocking. If they don't want the Spock look, so who doesn't want Spock look? Men. Men do not want the Spock look. In fact, I have a patient coming today who I injected as a first time. He's Asian, and for some reason, I think Asians are very sensitive to botulinum, especially Xeomin. So just a little bit will really cause a dramatic effect. So I always tell patients, I'm going to inject you. 2 weeks later, they come in to see me, and they may need enhancements. It's up to you guys if you want to charge for the enhancement, but I certainly say you have to come in 2 weeks. We're going to give you enhancements, and I tell them ahead of time, you have to pay for those enhancements, right? I don't tell them it's adjustments because it makes it look like you didn't do your job. You always want to look more natural because you cannot take away Botox, but you can always add Botox. So 2 weeks later, I have them come back. So that's what that does. It scrunches up your forehead, gives you those lines. Now, this muscle here, all right, this muscle here in the middle is your procerus muscle. This muscle is the one that gives you the 11 lines. They give you these vertical lines. You guys have seen, who has good lines? Go ahead and give me that angry look. angry, angry. So you have some 11 lines, not too bad. A little bit there too. So that's what that does. But when does botulinum toxin work the best? It works the best when you have dynamic wrinkles. So when you're at rest and you're not making any faces, if you don't have any lines, but when you make those faces, the angry face, the surprised look, the really big smile, and you get those lines, that's when botulinum toxin works the best. What happens to those patients who have this deep set 11 lines that when they're not making that angry face, it's still there? You want to tell them that botulinum toxin will help decrease, right, the depth of those lines, but it'll never really resolve it, okay? Setting patient expectations is the most important thing. God bless you. It's the most important thing because if you tell them you're going to look 100% beautiful without any adjustments and this is all going to go away, when they see themselves 2 weeks later, they're not going to be happy with you. They're going to think you're a horrible injector.
Yes.
Okay. So there are things, clinical pearls that we're going to teach of what you say to patients so that they know what to expect. And so it's almost like they expect they're going to come back and they're going to expect that they're going to get bruising. They're going to expect that they're going to get swelling, all right? Because if you don't bruise them and you don't swell them, you're God, right? But if you bruise them and you swell them and you already told them, then they already expect it, okay? All right, so that's the procerus. Now, what is this big muscle that surrounds your eye? Acts like a sphincter. That's the Orbicularis oculi muscle. And you know when you close your eyes really, really tight like this? That's what that muscle is doing. So what happens when you inject around that? It opens it up, all right? So when you're looking at crow's feet, lateral canthorhynchids, that's going to open that up. So that's going to give you that nice, rejuvenated, well-rested look. All right, nasalis here. You have your zygomaticus major on the bottom and minor, and these are more superficial muscles. This muscle is important here. This one medial, right next to the nose. It's a very thin slip of muscle that goes all the way down here. And what that muscle is called is the levator labii superioris aliquot nasi muscle. And what that does is that gummy smile muscle that you have. So when you smile, and then lateral to that, which is this, and then even a little bit of this, these two are the levator labii muscles, superioris, and then more lateral, the angular, okay, the angularis. And what that does is it helps you elevate that smile, but sometimes it's a little bit overactive, and that's when you get your gummy smile. So if you actually put 1 to 2 units of botulinum toxin here and here, just right next to your kind of, you know, to the ala of the nose, you can cause enough of a drop symmetrically to have a nice, beautiful smile without the gums showing. Anyone know what this muscle is here? This one right here? You ever see patients that have that downturned mouth, and then when they make that face? That's the depressor angularis oris muscle, the DAO as we call it. And for those patients who have that downturned smile, if you just inject 2 units here and 2 units here, it's going to lift everything up, all right? Here's the mentalis over here. These are the platysmal bands over here. Did I get everything? I think I did. Okay. Procerus in the middle and the corrugator supercilii muscle. That's when we inject the whole kind of glabellar complex, which is made up of the procerus, which causes what? It causes those 11 lines, right? And then the corrugator supercilii, the medial and the lateral heads. They insert deeper than the frontalis muscle, right? So you see the frontalis muscle over here? So you actually have to inject a little bit deeper. As you go more lateral, the corrugator muscles are more wispy and more thin. So what does that mean? That means when you inject, you're going to go more superficial, okay? So next slide. Okay, so a little bit of a quiz so everyone knows our anatomy. What's number 1? Okay, frontalis. All right. What's number 4? Okay, what's number 3? Corrugators, right? You get the medial and the lateral heads. Number 6 is oculi, right? Because you also have number 12 would be orbicularis oris muscle. 7 is the nasalis. 8 is the long name, which is levator labii superioris, the liquid nasi muscle. 9 is going to be your levator labii superioris, and then angularis is going to be a little bit more lateral to that. 10 and 11 are the zygomaticus major and minor. So those you would only need to ever inject, and nobody really does this. If they really have a very lateral gummy smile, you may want to inject a little bit more lateral, but nobody really does that here. And the 15 is platysma, 6 is your DAOs, and depressor anguli oris muscle here, and then 18 is your mentalis. Okay, let's go into the next one.
Does it change your speech when you do it down here?
It does. So I always tell patients, if you're injecting anywhere around the mouth, whistling can be an issue. Playing a trumpet could be an issue. You know, I guess possibly singing if you're using your mouth in a certain way to sing. So for those patients who, you know, their job is to sing or play trumpet, or, you know, most of the time it's a very strange feeling that they have to get used to. So there are people who don't like to get injected around the lips, and also it hurts too. Who likes to get injected by the lips? I'm going to tell you. The people that have smoker lines really see a difference for sure, but you could also put fillers in the smoker lines. The younger kind of millennial, you know, liking the lip flip, they don't mind that, you know, they have oral incompetence, which means they can't really purse their lips. Like drinking soup is okay, you know, but if they really want to do that face, it's a little tough for them to do it.
Like
Now,
straw.
drinking through a straw, exactly, that type of thing where you're really kind of pursing your lips can be a little bit tough. That doesn't close all the way. But that doesn't last forever, right? So how long does botulinum toxin work? What do you tell patients? Someone comes into you and they said, Doc, how long is this going to work? What are you going to tell them?
3 to 4 months.
3 to 4 months, okay? And never say 6 months. Why? You tell them 6 months and they start to wear off at 3 months, they're going to come to you and say, you gave me bad Botox, or you gave me Russian Dysport, you know. So you tell them in 3 months you're going to start noticing a difference. But the difference is within 6 months everything will be out of their system already. But they're going to start to see wrinkling at 3 months. So you tell them 3 months so that they know what to expect and they don't think you did a bad job when in 3 months they start to get their wrinkles. And you'll see, and you'll tell them, as you come more, you're going to need less and less, right? And you're going to tell them, it is preventative. It is preventative for creases. Think of it as a piece of paper, right? Once you crease that piece of paper, very, very difficult to uncrease that piece of paper. So you want to prevent it. That's what you want to tell patients. So Frontalis, what does it do? It raises the eyebrows, raises this is the major raiser of the brows, causes those horizontal rhytids. Corrugators, it drags everything down medially, so like when you're angry and you're giving that look, that's what's really going on there. Procerus, so the procerus pulls the brows together. So when you're injecting the procerus, what you're going to also notice is that the brows are going to become more lateral. Okay, so what do you do with that patient that already has very lateralized brow? You have to tell them this is something you should expect. Okay, another clinical pearl. Before you do any injection, you have that patient look in the mirror, because they will never notice the amount of asymmetry that they have, the little bump here. Anything that's, you know, that you see, you have to point out to them, because if you don't, they are going to be looking in a mirror every minute of the day after you inject them. Okay, they're going to say, has it started working yet? And if they see some asymmetry, they're going to blame it on you. And then that's when you show your before picture and you say, look, that you had that before. Even better, point it out to them beforehand so that they know. All right. Orbicularis oculi for the lateral canthal rhytids, and to open up immediately as well, levator palpebrae. So back in the picture where I showed you, you had your frontalis muscle, and then you have your orbicularis oculi muscles. This part is the palpebrae muscle. All right. So this is what causes the lid lift. If there is some dispersion of botulinum toxin into that area, you're going to get lid ptosis, something that nobody wants. It's undesirable, to say the least. Okay. So next.
So
Okay.
to prevent that, you have to go higher.
So to prevent it, there's like 5 to 7 things you can do.
Okay.
and I will go over those clinical pearls. So how much do you tell a patient that they need? Because this is what the next question is going to be, all right? They're going to tell you, Doc, I'm coming here because I have this and this. I always have them come in and I always ask them, is there anything on, on your face or your body that's bothering you? Why do I say that? Because if you start telling them, oh, look at these crow's feet, and they're like, whoa, I like my crow's feet, and they do. People love their crow's feet. They do. But not everyone loves this, but crow's feet is plus or minus. But you have to ask them, what they want. And then once they tell you that, the next question that they have is, how long does it last and so forth. How much does it cost? All right, so I know, Nairi, you said you don't really talk costs in the office. A lot of patients will just call and say how much per unit or how much per area. And a lot of patients actually don't know what per unit means. So you could say, oh, it costs $20 per unit. And they're like, well, what does that mean?
Yeah.
You don't know until you examine the patient. So do you price it by unit or do you price it by area? 300 per area, maybe a little bit easier mathematically, and for the patient to understand. Okay. For women, you do less because women usually have thinner muscles that are less hypertrophic than men. So 10 to 20 units for women on the forehead, while in men you want to do 20 to 30. Here are the clinical pearls. You want to stay superficial in the forehead. Remember that muscle I just showed you? How thin and wispy is that muscle? We're not talking about masseters here. We're talking about very superficial muscles. You just want to get right underneath the skin and cause a little bit of a mosquito bite right there. You also look to see how their face is and how their brows are. For women, we like that nice high arch, right? So you may want to inject according to the curvature of the forehead. Where in men, it's usually more flat across, and I'll show you some of that as well. Now, what's the problem with injecting too much in the forehead? What do you guys think? What are patients going to complain of? Heavy forehead, maybe a brow droop, but heavy forehead. When you want to look surprised and that forehead is not moving, sometimes it can be a little bit uncomfortable. So one of my patients that I put 24 units in on her forehead. She was someone that came to me twice before. She hated needles. She was coming from out of town. And I said, all right, instead of doing a little less, this is the third time, I'm going to put a little bit more this time, but it's going to last for a while. I never say 6 months, but it lasted her over 6 months. I put 24 units across her forehead. She was frozen, but in a good way. She was frozen in a good way, but she felt like it was heavy. And so some women don't like that heavy feeling, and so they're going to complain. Things feel a little heavy, and you just tell them it's going to get better. Do your exercises; it's going to get better. A lot of it is hand holding and reassuring, but you look great. You have no wrinkles. You look amazing. And then after 2 weeks, sure enough, no, it looks great. I really love it. Thank you. So glabellar, I always start with about 20, unless less if it's Asians, or less if it's if they really don't have much there. So 20 in the glabellar area, which means 4 here. And then at the corrugators on each side, medial and lateral heads, another 4 units. So 4 times 5 is 20 units. And then you could do up to 40 units. But what's the problem? Putting too much here, it can disperse onto your levator palpebrae muscle and cause a little bit of ptosis. So you want to be careful. There was one physician that actually injected 200 units into a man, not at the same time, and she also didn't dilute the normal way. She diluted with much less. So you can actually dilute with 1 cc's of preservative normal saline versus a 2.5. It gives you less saline to diffuse, and she did it in kind of different, 2 or 3 different times to get that procerus to relax. And then crow's feet, 6 to 12 on each side in women. I usually like to start, with 6 to 12. And you do it 1 centimeter outside the orbital rim. All right, most of these injections are going to be outside the orbital rim. We're going to talk about where you're going to put that injection. And then the brow lift, 1 to 4 units on each side, right underneath it. Now, people draw on their eyebrows now. So their eyebrow may not be, the eyebrows should never be your landmark, because everyone's eyebrows are different. But you feel for the orbital rim, right? You have them go like this, you have them go like this. You feel for that muscle. Put 1 unit and 1 unit here. And what that does, so the glabellar injection will open things up medially, and then the 1 lateral brow will then open things up here. So people love the lateral brow injection. Okay, next one. Okay, so how do you reconstitute? So today we're going to go over how to reconstitute. You're actually going to reconstitute your own, whether it's Dysport or Xeomin that we're going to use today. You're going to use 2.5 cc's of the saline injected into each 100, or for Dysport it's going to be 300. So Dysport's different, it's about 1 to 3. The bottom line is you're going to inject the same amount and you're going to remember how many units are in each 0.1 cc. The easiest way and the hardest thing about botulinum toxin is not how you're going to inject, where you're going to inject, technique, it's the math. It really is the hardest thing. And when we inject today, you guys are going to be doing math in your head. You're going to be like, oh my gosh, I can't do this because I can't understand the math. You just need to remember one thing. So if you remember nothing else from this didactic course, remember that each time you inject, and now this is obviously the way that we're diluting is 2.5 cc's of the normal saline into the bottle of whatever you have. Each time you inject 0.1 cc's, you're injecting 4 units. That goes for Xeomin and Botox only. So do you guys want to repeat that with me? 0.1 cc's equals how many units? 4 units. Okay. So Dysport's a little bit different. Dysport is 300 to 1. So you have to have at least 2 to 3 times more Dysport to equal the effect of 1 unit of each. All right. So what that means is I inject Dysport the same way that I inject Botox and Xeomin, but at the end, when you document, you just multiply that number by 3, and that's how you get it.
Or more unit?
It's the same. It's the same volume that you're going to be, because it comes as a dried crystal, right? Exactly. So it's however much you want to put into it. Okay. So a lot of people are not excited about Dysport because they don't know how to do the math. But if you just pretend it's Botox or Xeomin and you inject it the same way, at the end you just multiply by 3. Who likes Dysport? Who likes Xeomin? And who likes botulinum toxin? Only a couple of people will come in telling you they want something specific. A lot of it is market driven, right? MERS just did a huge campaign with Christy Brinkley and Althera, Althera and Xeomin, all right? So they may come in, they say, it's more purified and it doesn't have all the proteins. I want that.
In the United States,
Right, exactly. Right. And so if you do, Botox made in China? No.
No?
Ireland.
Ireland.
Oh.
Yeah, Botox made in Ireland. So Dysport, I find men like Dysport. I find Dysport sometimes to work better, right? I don't know if you feel the same way. I would say better.
Not better. People will notice it works a little bit faster.
It is
and
faster.
Some people, it may last a little bit longer.
Maybe a little bit longer.
Maybe a little bit longer.
Right.
And that's maybe.
And we don't want to tell patients that, right?
No.
I also don't
What's your
charge
experience
differently.
with Xeomin? Do you think it lasts shorter? That's what some people
I'll tell you what I think. I'm a fan of Xeomin.
Yeah.
Yeah. Number one, it's cheaper. It's $482 versus $601.
Yeah.
Right? I think I've never done a head-to-head study, but I use Xeomin on myself. Yeah. I'm happy with the results. Maybe in certain patients it doesn't last as long, but everyone's also a little different.
Right.
I don't know what you use. You don't.
like it.
He doesn't like it. Yeah.
You don't like Xeomin?
Why? Do you think it?
I personally felt it doesn't last as long.
Okay, that's what a lot of people say. But I use
That's-
Xeomin on myself as
You
well.
look great.
And you look great, right?
Right, but you two are outside of the normal aging
Right.
protocol. All right,
Yeah.
ethnic skin does not
That's true.
typically
Very
age
true.
in the same way as Caucasian skin.
Yeah.
Asians love Xeomin. That's all. It works really well in Asian skin. Xeomin works really well.
I use both.
Dysport, the men and maybe the younger, they know the term Dysport. Okay. Obviously, we're going to go over everything. Don't shake it. It's more like a swirl, and then they're back and forth. You don't want to make it foam, denature the protein. So Dysport works 24 to 48 hours. Botulinum toxin, 3 to 5, did I say hours? Days, 24 to 48 hours, which is 1 to 2 days. And then the others are usually 3 to 5 days. But I never tell patients that they're going to see results in 3 to 5 days. I tell them you're going to see results in 2 weeks. Okay, because if they start seeing results at 3 to 5 days, you're amazing. But if they don't see results in 3 to 5 days, you've given them bad
That's it.
Botox. It's all about telling patients what to expect. The other thing that they're going to do too is that they're going to be staring at that face for 24 to 48 hours because you told them that things are going to change, and they're going to still see that wrinkle, and they're going to say, you told me things are going to change. But after 2 weeks, everything should settle, right? And that's when you have them come back, and if they do have a little bit of spocking, 1 unit here, 1 unit here, just to drop it a little bit so they look more natural and not always surprised. So that's important. Okay,
The
next.
asymmetry thing you said is really key. A lot of people, they don't notice their face is asymmetric.
Right, right.
And then because they're staring at it all day,
Yes.
like, oh, you made one eyebrow higher than the other.
Yes.
But that's just how they work.
Everybody's asymmetric.
Yes.
And the line that I always use is you get a PhD in asymmetry as soon as I put the needle in your face.
Right. Yeah.
Right? Because nobody knows that they're asymmetric, even though when it's pretty obvious.
Yeah.
Now, sometimes patients are not as asymmetric in resting face, but they, you know, maybe one eyebrow always goes up a little bit more. And Fatima, I noticed as you're looking at me, your right eyebrow likes to go up a little bit. Some people have, like, they just one eyebrow, you know, they can do that eyebrow thing. I don't know how to do that, but
And the lips
also I'm a little
especially.
frozen. Lips, eyebrows, face, volume of their face. Now, we all drive, most of us drive, and we're constantly being bombarded with sun on our left side. Different than when you're going to Europe, everything's on the other side, right? Unless you're a mailman here. But most of the time it's coming from here. And people sleep on their face.
Yeah.
When you sleep on your face, you are causing wrinkles. This morning I woke up with all these lines on my face. I'm like, because you're putting pressure on there. So everyone's face is asymmetric. And when we evaluate all of our patients today and all of our models, everyone's face is asymmetrical, and you have to point that out to them and take a picture and show it to them. That has gotten me out of a lot of, questions of, I noticed that this was 1 millimeter, lower than the, oh, look how bad it was before, oh, this is great, thank you so much, I love you, You don't say it like that,
Right.
but it gets you out of a lot of trouble. Same thing with cool sculpting. Cool sculpting takes, a few months to get the maximal results. When you look at yourself in the mirror every day, you do not notice that you're losing the weight. Right? Until you do before and after. I've had patients that have dramatic changes, and they're like, I don't think it's changed. I take a picture of them, they're like, it's a world of difference. They just don't know because they're always staring at themselves. Okay. So what do you want to do? You want to put it in a refrigerator. It could be just any refrigerator, usually about 8 degrees Celsius. Put it in the back if it's your normal refrigerator. You should keep everything separate, for, medication versus food, obviously. You should always put the date and the time that you opened it. Okay. Next. Yeah, that'll be the next. Was that the next slide? Okay. No. Okay. What the manufacturers will say is after reconstitution, you have to use it within 24 hours. Okay?
Wow.
But if you've actually used it on a patient, which I don't really understand this, it's within 4 hours. And each bottle should be used for one patient. That's what the manufacturers say. Now, if we all did that and discarded the Botox, we would go bankrupt day one, right? So the true answer is you have to inject it within, 4 hours, use the whole thing and within 4 hours, and then after reconstitution, it's good for 24 hours before you inject it. But, yeah, okay. So that's how long it lasts, for 4 hours that you should inject. We'll talk about more later. Okay. This is just a comparison. Go ahead, next one. Okay. This is the difference between the units. We already went through this. Go ahead for the next one, Hardig. Okay. Costs. Costs are for Botox, for botulinum toxin, for Botox specifically, it's $9.99 per unit versus Dysport at $3.99. But that's because in Dysport you have to use double, triple the amount, beforehand. So this is what your bottom line is. All right. So you can kind of figure out what you need to price it at so that it's enough to pay for the cost of the product, your needles, your syringes, and everything else, plus you have overhead, and plus either if you're injecting or you're hiring someone to inject, you have to pay for them too.
So the $9 includes like your practice cost, is that what that is?
Yeah, this includes the practice cost because obviously it's only really $6 and
Right.
$6 per unit. But with everything else included, that's really how much it costs, about $10. So how do spas get away with charging $10 per unit?
Right.
And we can talk offline about that as well. All right. So we talked a little bit about the diffusion and the drift. Go ahead, next one. Okay. The concentration dilution, we'll skip that for now because we're going to do it all the same way. Okay, so patient consultation. So what do you want to do when you get a history? Well, you always want to get a complete history. That's number one. You want to take photos of various views and review with the patient. So photos, straight on, at the same area. Do not zoom. You can take it with a tripod and a camera if you have a room set up for that. That would be the best way. But if you don't, you can just do it on your iPhone. That way you can always do before and afters and show them. You want them looking at you straight. I do two things. I do one without flash and one with flash. You don't really want overhead lighting because overhead lighting really shadows a lot of body and face, and so you kind of want more natural lighting coming at you this way. You want to have them normal, natural face, neutral position. Then you want to have them look surprised, angry, and smile really, really big. Then you want to go on a 45-degree angle where the nose and the cheek line up, and then you want to go on a 90-degree angle so you could see their profile. Sometimes if you're doing like malar cheek injections, you may want to go on top just to see, just so patients can see how it actually protrudes more. But if you do this the same way for every patient, because the consistency is key. When patients look at your photos, and it's so hard to take a photo with the same exact lighting every single time. Even if I did a photo now and I took one 2 seconds later, it's going to look different, right? But patients are very, very critical. So you have to have the same lighting. You have to have the same expression at every time and the same eye level. Okay. So discuss anticipated results. All right, so we talked a little bit about patient expectations. What you want to tell them is this. We want you to look more rejuvenated. We want you to look more like you've slept, for like a year. We want you to look younger. And you don't want to tell them they're going to look 10 years younger because everyone's a little bit different. And most patients are coming to you, especially as a first timer, they may not know what to expect. And you just tell them, it'll make you look more rejuvenated, like you've slept, and that you're relaxed, and it'll open up your eyes more, and you'll be more rejuvenated. They love that term. You just tell them they look rejuvenated, they're like, okay, sign me up. Possible complications, that's important too. As injectors, we have to tell them the complications are going to be, redness, swelling, bruising, brow ptosis, lid ptosis, possible scarring. Those are things you have to tell the patient. You could also include it in their consent forms as they look through it. So who's an ideal candidate? Because I know a lot of you guys are bringing in models. Maybe not a lot of you know who the ideal candidate is. Ideal candidate is someone, at least for botulinum toxin, who has lines, right? We call them dynamic lines when they're making a face, but not necessarily static lines, because once they're set in and they're deep set, you're going to have to do every 3 months botulinum toxin, botulinum toxin, botulinum toxin, and you may even have to do a little filler on top of that to get rid of that crease. All right? We're not going to actually do any. We're not going to really talk about doing any fillers in the glabella area because there's potential complication and risk of blindness. There's been case reports. I've done, I think, a few, but I always stay very superficial. But there's so many other things that you can do in that area that's not a filler that is safer, whether it's laser or IPL, certain things like that. PRP. I think PRP. Yeah, we talked about PRP. I probably would not suggest anyone just starting out to do anything that has high risk of complications and injecting in areas. That's why we're not teaching, liquid rhinoplasties today. It's something that you really have to know the blood supply, understand it, and know how to recognize complications once they happen and know how to fix it or send them to someone who can fix it for you. Patients to avoid, oh gosh, this is like a topic in and of itself. So, if you get like the 80-year-old woman who has, a ton of wrinkles, you really can't improve much on them. Or someone that actually needs a facelift, right? Don't oversell it so that you can tell that you're telling them it's going to be equal to that of a facelift or surgery, because it's not, right? For those patients who want or need surgery, if they have a lot of mid-face sagging, a lot of bone loss in their mid-face, and everything is just coming down, you can put all the filler, you can do the threads, you can do botulinum toxin all you want, But if it's not going to give them what they expect, they're going to come back to you and they're going to say, I just spent, $12,000 and I'm not getting the results that I want. So a lot of it is just knowing when to tell patients, I can't, I can do the tear troughs for you, but what you really need is a blepharoplasty, right? So you have to know which patients to tell. Patients to avoid, I would say, online, there are going to be people who are going to come to you and they just want their free consultation. And that's okay. In the beginning, you practice, you want to talk to these people. But if someone's coming to you and already, even before talking to you about anything, even before talking to you about, what they really need, and they're like, okay, how much is it going to cost? Because I found this Groupon. It's very, very hard to please those patients. Very, very hard. And I found that out the hard way. I actually still have a patient who wants to come see me after, after this whole thing. And I'm trying to decide whether or not I want to see him back. But it's tough because on the one hand, Groupon, there's a lot of Grouponers out there and they do get a good deal. The bottom line is if you're a physician and you're injecting and you have the know-how, you have the license, you have all the training behind you, know what you're worth is the bottom line. So these Groupon seekers, if they're just coming and they want the deal and they want you to match the deal of $7 per unit, which means you're pretty much paying for them, right, to get the procedure done, you may not want that patient because they may not come back to you a second time around. Okay. Patients new to fillers should be treated with reversible fillers. So that means the hyaluronic acid fillers. That makes sense. Skin thickness is important. Also knowing what surgeries they've had done. So a patient who has very, very thin skin, who's had fat injected, who's had rhinoplasty, who's had a facelift, those patients are not the patients you want to start injecting right away because there's different blood supply to the area. The deposit of fillers may be different because of the fact that they've had fat fillers before. So just be a little bit judicious in those patients. Next. Okay, so how do we inject? So remember when I told you kind of go with the natural curve of the female patient's brow? So 1 to 2 units in each of these areas, at least 2 centimeters above the brow. Very quick thing, split the forehead in half and inject there and above, that's it, all right? But what happens when patients have this little comma that you see, because they'll do this for you and everything is nice and relaxed except for a little wrinkle here and there. You could put 1 unit here and 1 unit here to lower that a little bit, but you have to tell them that's going to drop your arch. They have to know that, all right? If they're okay with dropping their arch, then you do it. Otherwise, they're going to say, you got rid of my beautiful arch. Because you do not want to inject right in here or right in here because that will drop the arch. Next.
But you would do that after 2 weeks. 2 weeks.
This is just doing the forehead after you do the glabella. The glabella should have been first, and then doing the forehead concomitantly. Yeah. So you want to go. So the Spock look is if you don't go, lateral enough, you get more central, and then this whole area is nice, but then this area is not. So that's when you put the 1 to 2 units here. But just in general, as you're injecting forehead, that picture that I showed you before should be how you're mapping that out. Here, 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 here. And at most, I would do at most 20, but I really would start 12 to 14 units in the beginning, unless they have really, really strong, forehead lines. The glabella is always first. Why do I inject glabella first? Because like I said, you never want to inject frontalis without injecting glabella. The glabella area is always first. And it hurts a little bit less. And so when you first inject and they're like, oh, that wasn't so bad. And then you go on to the more, painful areas. So 4 units, right? You can draw that line, make that little X and draw right into it. But really, you just have to make that angry face. And wherever that kind of protrusion of that horizontal line above that is where you inject. And then you inject 1 centimeter above the brow. Now, some people like to inject right on the brow. Some people like to inject 1 centimeter up on the brow. The differences are really subtle. The difference what we don't want is to diffuse onto the levator pupillary muscle. And so we want to inject just slightly higher than that. All right. Next.
So it's 4 units here. What about
4, 4, 4, 4, 4, unless, right, they don't really have that much of a lateral corrugator, then it's 4, 4, 4, 2, 2. Remember, everyone's different. So although this is just a template we're showing you, look at the patient, everyone's different, tailor it to that patient and see what they want to. You know, they may not want a lot. So there's also some people who have this kind of weird omega sign. I don't know if you've seen certain people that do that. In this case, what I would do is I would inject here, 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 but I would also inject right here as well. Now, you probably would have gotten that anyways with the forehead one, but you could actually inject a little bit lower just in someone like this, okay? Go ahead, next one. Okay, what do you guys see here? He's coming tomorrow, by the way. He's our ENT. Do you see his medial corrugators? Do you see how strong those are? That's going to take a lot, right, to get those to relax, and he's going to need a lot. But you see how the corrugators are just very, very thick. And so what you want to tell this patient, you're not going to say, well, we're going to get rid of your 11 lines. But he looked angry all the time, right? And so little by little, you know, we inject him little by little. That will go away. All right, next one.
How do you actually know how many units to put into the muscle?
Okay, that's a good question. And then the other question is kind of clinical pearls and things like that of how you inject to decrease your risk of lid ptosis, right? So I can answer those now. So number one, you never really know how much to inject unless, one, you have a record of how much they were injected beforehand, or number two, does that keep talking? I hear something. Okay. Number two, you inject them for the first time, lower amount, and then the next time they come back, and then you inject them again. And then you put it down on your H&P of how many they really need, and so the next time you could just go straight to that. You know,
I was going to ask you, so if you did, let's say for some reason you did 2, and then 5 days later you did 2 more. The next time, 4 months later, fresh, would you do 4 at once?
It all depends.
It all depends.
It all depends if they come to you 4 months later, which maybe you may not have to because remember, it's kind of cumulative.
That's true. Okay.
And you may just need to put 2, but if they haven't come back to you in a year, then
Where it's
yes.
all gone,
Where it's
yeah.
all gone, then I
But
would start with
4
that.
months later, if they have residual, maybe you just need that 2 again.
Exactly, and that's what you tell them. Come to see me in 3 or 4 months. We'll get you, come to see me in 3 to 4 months, and you don't need as much, so you're not going to pay as much.
Additive thing.
Yeah,
Okay.
but the first time, you got to do it right. You got to tell them, I'm going to do it right. We're going to make you look good, but this is how much you need. Some patients are like, well, I only have $200. What can you get me? No. Be careful about those patients because they will never be happy because they're not getting the amount that they need.
Yeah.
Right, so be careful about those patients that are like, I only have this amount of money. What can you do for me? If you really want good results, pay for it.
Yeah, it's not good.
Pay for it the first time around. Every time after that will be less. Okay, so that's how you sell it. Lateral canthorhynchids, 2, 4, 6 I start with. If it's really minimal, I do a little bit more, up to 12 units on each side if it's thicker. So how do you know how deep to inject? How do you know how much to inject? And what do you do to prevent lid ptosis? There's different ways of doing it, right? We do a lot of pinching technique. So I pinch here, I put in straight in. For the glabellar, I do 4 units straight in. And then for the corrugators, I put my thumb underneath the supraorbital rim. That will decrease the risk of the dispersion, right? And I always, of a dispersion of the botulinum, once it's reconstituted, I always inject slightly upward. If you inject downward, that can also cause lid ptosis, right? Because of the fluid going into that muscle, the levator papillae. The other thing I do too is, and as you'll see, as the muscles are thinner, you want to go more tangentially instead of straight in, right? Because you don't want to go all the way to the periosteum. Once you go to the periosteum, number one, it hurts, and number two, it can actually diffuse quicker, right, into the levator papillae muscle. So those are the tricks to decrease the risk of ptosis. You got to tell these patients, don't run a marathon, don't put a hat on afterwards, don't mess with your face, don't get a facial, don't do a facial massage. You got to tell them these things. Don't go into a sauna because that's what happens. They'll put a cap on, they'll go to a sauna, they'll run a marathon, and then things are starting to droop a little bit. All right, so let's go back to those pearls again. How do you decrease lid ptosis? Make sure that you don't over dilute with saline. You do the normal dilution we talked about. Put your thumb underneath, upward, keep it there for a bit. All right. Now, what happens if someone has some bleeding? What do we always do when we see someone have bleeding? You put pressure on it, right?
Yeah.
So be careful when you put pressure. You're not putting pressure and pushing it down. So just keep your finger there, but put pressure on there too. All right, so that's the most important thing too. When you see bleeding, put pressure on it right away. But if it's near the eyes and it's Botox, just keep your finger on there. And don't go too deep, point upwards, and just tell the patient what they should not do afterwards. There should be post instructions so they have it. There was someone who was in a litigation because they didn't have proper post instructions, you know, and they didn't know what to expect and so forth. So post instruction care is very important as well. Okay, next. All right, this is just showing the lateral canthal rhytids. Go ahead, next. All right, the brow lift. This is where you want to put the brow lift. Just lateral to lift up that brow. Because remember, you're lifting things up medially by doing the glabella, right? Because the glabella pulls things in, makes that angry face. When you inject that glabella, it opens up, right, medially, but you need something that opens up laterally. So that's the lateral Botox lift.
Get that?
Yes.
Right.
Yes. I had someone come to me from Instagram. She had tons of followers, like 28,000 followers. She just wanted a brow lift.
Yeah.
So I just did 1 unit here, 1 unit here. And then she wrote, you know, Dr. Lana gives the best, she slays the brow lift. After that, I got multiple people wanting me to do their Botox. Okay. So next, and it's so here's the other thing too. Anything that's, you know, kind of off label. I mean, if someone's coming to you for this, you're not going to charge them $20, right? The price has to be different. So that's when you want to say, if you want the brow lift, it's this set price. Don't talk about units with them because you're going to be $10. All right, next one.
So how much do you charge for that?
For the brow lift, you could say anywhere between 150 to 200, and they'll do it because they'll, you know, or the lip flip, 150 to 200. Yeah.
So is it better to price your Botox and stuff by area or by unit?
So everyone has a different way of doing it. I think people start out initially doing it by unit, and then they soon realize it's just so much easier, quicker, and patients understand more if you do it by area. You know, I think it's a little easier to, you know, you don't have to worry about the math and how many units did I put in this? I can't remember. You know.
Dispersion prices for men versus women then per area?
Yes. Yeah. Exactly. Yeah. Because you're using more.
More, yeah.
Mm-hmm. Yeah.
That's just brow lift.
This is brow lift. Yeah.
I like that.
This is just brow lift.
Oh, that's nice.
We talked a little bit about this earlier, so we can go. This is just kind of, you know, kind of lower face. So botulinum toxin, FDA approved for things here and above. These are all off label, right? Okay. So we talked a little bit about this. Okay. So botulinum toxin of the lower face. We talked about the gummy smile, 1 to 2 units on each side over here. The smoker lines, we have pictures of that. Downturned oral commissures is 2 to 5 units on the DAOs. The chin dimpling is 2 to 3 units per side. Masseter hypertrophy, depending on how hypertrophy their masseters are, you may need up to 50 units on each side, but I never start with that high. I start with about, myself, I started with like 10 and 10, and then maybe at some point we maybe do 20 and 20, but you never want to start too high. You're going to get some parotid atrophy, some parotid gland atrophy. You don't want to inject it into the parotid duct because then you're going to get xerostomia, you're going to get dry mouth and so forth, and very annoying. So you want to stay kind of on the lower end of the masseters to get that. Now, some people actually go midline and kind of march up the masseters. You just have to be careful you know where you're injecting so you're not injecting right into the duct itself. All right, next.
I have a question.
Yeah.
Why would people want that? I just never heard of a client ever ask.
Everyone will benefit from this because it makes, you know, when those women that come to you, especially Asians that have these big kind of round faces, it slims your face and it contours your face. What is beauty? Beauty is that nice V-shaped, kind of heart-shaped face. That's what beauty is. Symmetry and that heart-shaped face. So if they come to you and they have, you know, really, really kind of protruding masseters and their faces are really round, you can slim their face just with Botox. And I have some pictures, and even on myself, my face is so much slimmer just by putting 10 units here and 10 units here. Okay. Right? So it makes you look thinner and more contoured. Everyone loves the contoured look these days. This is what, this is the makeup world. The contouring, this is key for contouring. Yeah. And that's just for cosmetic purposes. For other things like TMJ, teeth grinding, you know, headaches, migraines, that could help. Yeah, that will help decrease that completely. So even if they don't save for the cosmetic, you know, it's good for those purposes as well.
Is it just one spot?
Some people just do one shot and they just go right on in because it does diffuse a little bit. I like to go in several areas. Some people actually map it out and go 4 areas. Some people do 2 areas. It depends on the masseter and depends on the person. But I would say I've seen a lot of people inject just one spot, and I'm sure that works just fine. You also have to get it into the masseter muscle. So you got to feel for it. You got to know how thick it is. Some people start by putting their 2 fingers in there. You don't want to go too deep. You don't want to go too superficial and just get the buccinator muscle. And then now they're going to have some kind of weird, contouring of the face. So the depth of the needle and the depth of where things go is very important because you have to mentally see where the muscle is to know how deep you have to go. So someone says, well, how deep do I have to go? Everyone's different. It depends on the muscle that you're trying to get, right? If it's very superficial, you want to make it very acute and just inject very slowly into it, facing up on the frontalis. But if it's something big like this, straight in, masseter straight in, right? So it's right into that muscle. Yeah.
How do you know how to avoid, how to avoid the duct, the carotid duct?
When you the picture, the bottom line is the duct we know runs like this, and it's also more anterior. Right? You get your facial nerve coming out of the parotid duct and it splits into that 5, right? 10 zebras bit my cute posterior, right? Posterior auricular is the last one. But if you just stay away from kind of injecting kind of in this direction, you're not going to get the duct. And you're injecting here in the mid, I try not to do too high up is the bottom line. I stay low. That's how you know you're going to avoid. Now, you're going to get some parotid atrophy for sure. All right? And over time, it may not grow back. But patients will be happy because they don't have that big.
They look cute. Thanks.
Exactly. We had a really great picture of one of our physicians who had very kind of big angular jaw. And we may even have it here in our patient selection. Okay, next one.
So what else do you feel though after you do that? Does your speech change?
No. It's a muscle of mastication, right?
So
Right.
difficulty chewing?
No, because it's a very big muscle. It's a very big muscle, right? So you have your masseters, you have your temporalis, you have your medial lateral pterygoids. Those are the 4 muscles of mastication. The masseters are so big that if you're putting 10 to 20 units in them, you're still going to be able to chew. It's not going to, right? It's just one of the 4 muscles of mastication.
Right, and the primary muscles are the medial and lateral pterygoid muscles.
And the temporalis, actually. Temporalis, medial lateral pterygoids, yeah.
So what you do is as long as you go on the inferior half of the masseter muscle, and it's very easy to feel in someone who's got it very prominent, you're fine. If you put too much, they get something called buccal redundancy, where the food actually starts accumulating in their cheek, and it drives them nuts.
Yeah, so you don't want to do too superficial. We have special syringes that go, special syringes, just deep, longer syringes.
This is the
Yeah.
tuberculin syringes, you just bury the hub.
Yeah. This is the smoker lines. That's also where the lip flip is, too. So the same thing. All right, go ahead,
How many
next.
units do you put there?
I do 1 to 2. So she's probably someone that at least needs 2, and then I have her come back. And she may need a little bit of filler in those lip lines as well. There's certain things, Bellatero, Volbella, those are really good for these lip lines because they're very thin, low G prime.
When you hear complications of someone getting like the Bell's palsy from Botox, is that just the ptosis that's happening at the eye, or is there more to it?
Okay, so
Face.
Bell's palsy. Bell's palsy happens when the facial nerve is affected, right? The facial nerve, as you know, exits through here, right? It comes out the styloforamen and comes out here, and then it splits. So it's very, very difficult to actually get the nerve for Bell's palsy. It's every time, if there is a Bell's palsy, it may be something completely unrelated, to be honest with you, right? Because people wake up with Bell's palsy and we don't know why. My mother, I injected her and she had Bell's palsy and I was like, oh my gosh, she has a stroke. And I'm like, what did I just do to my mother? And I was like, I quit. I will never do this again. No, she's fine. Put them on some steroids and she was fine. It actually had nothing to do with it. It was just, yeah.
Idiopathic, right? Yeah.
It's idiopathic, but I will tell you, it happened to my mother. Timing was not great, and I don't know. And I looked to see if there was case reports on this, and there wasn't. But yeah, there's no reports to actually say that you're going to inject that, and it's going to get all 5 facial nerves of the motor, part of the facial nerve.
Yeah, so before hearing it with your mom, there was one nurse in residency, I remember, that had it, and so she couldn't smile almost at her face, and to this day, 4 years later, she's still.
But Botox, we don't even inject around the facial nerve.
She had it just like the crow's feet in the forehead, and within a very close proximity to the injection, she had the Bell's palsy.
I would say that who really knows, but I would
it was
say
also one of those group
maybe a
situations.
reaction.
Anything with botulinum toxin is reversible, right? So if she has long-lasting thing, it's not from the botulinum. Yeah, it's not from the botulinum. There's something else that happened, and it just so happens with it.
It coincided with the time of the injection.
Right, because what they say about Bell's palsy, I think they say like if you have like a window open and then you get the breeze. I mean, it's very weird. We don't really know what causes Bell's palsy, but I did have one. My colleague, he injected just mid-face Voluma for cheek augmentation, and his patient had Bell's palsy like 2 days later, but nowhere near, near that. So, anyways, resolved completely. Put him on a steroid pack and resolved. Okay, so that's that. Let's go into the next one. So the downturn oral commissures, right? These are the DAOs, depressor anguli oris muscle. There's two ways that you can inject. You can go 1 centimeter lateral to the oral commissures and then 1 centimeter down, or you can actually go from the bottom up, from the jawline up. I tend to like to go here from the bottom up, and that will then decrease that pulling, and it'll. Yeah, we can do that to you today if you want. Next. Okay, so mastoid hypertrophy, we talked about this. So you see how low they are on the jawline? Now you can march up just to get that hole, but most of the patients that we see, it's really just the bottom is really the issue, right? They're not huge the whole way up. It's really just the bottom. It makes it angular, it makes it look bigger, and so those patients who really want that kind of slim look, you can actually go a little bit further up on them. Okay, next. Right, because again, parotid, facial, everything is more anterior. Side effects, pain, bruising, erythema, swelling, and mild headache. All right, I've had patients who said they have mild headache. I had one patient who actually had some flu-like symptoms. A little bit of diarrhea, a little bit of like malaise, body aches, and you tell them 24 to 48 hours and it will be gone. You reassure them, reassure them, reassure them. It is very rare, but I had one patient.
There's one lady that's coming in today that said that she had something done and she had like diarrhea from it, but it went away.
Yeah.
So
So
filler with
happening
a bovine
again?
filler.
if it's bovine,
Ballafil?
yeah,
Must be Ballafil then.
yeah.
Bovine.
If it's bovine, yeah. I mean, with those patients, you do a test patch, or you just have them sign a waiver that says you're okay. Don't do the test patch,
I was gonna
right?
say, so do you think that would happen again to that person? I guess then
It's a
you wanna
possibility,
test it or
yeah.
something?
The other
Yeah.
thing too,
Oh,
right?
A little diarrhea, look good.
It'll make them skinnier.
Right.
They will come back.
Body contouring included.
They'll be like anorexic.
They will come back because they look good.
Terrible.
What else was I going to say about that? That was funny.
So testing, that's interesting. You can do a test, right? Just like a little unit or something?
Yes, you can do that, yeah. Besides the feeling of heaviness, besides a little bit of mild headache, besides the flu-like symptoms, was there anything else that I missed?
Well, I always say more serious side effects have been associated with botulinum toxin, difficulty breathing, difficulty swallowing. But that typically is not for cosmetic Botox.
Yeah.
But I just bring it up. It's
Yeah.
all in my consent form.
Yeah.
I mean, everything you can think of. It's just there.
It takes 3,000 units to paralyze somebody.
Right.
What we're using for cosmetic is
Right.
very, very low. We're not doing spasticity in those patients, so it's
Cerebral
very, very
palsy
low.
and
Right, right,
etc. That's correct.
right.
So do you have a patient, you were talking about the test spot, you have them sign a form that says, I'm not gonna do a test spot, I just wanna go to the procedure?
I don't, but that's only if you're doing something like Bellafil, where they actually require you to have, because of the bovine, so I don't do Bellafil. The other thing too, and this is important, testing your patients and so forth, getting a good history. Have they ever had injections before, and have they ever had syncopal episodes before? Because one of my first patients that I injected had a syncopal episode that lasted for like 5 minutes in my mind. It may have been less, but she was out for 5 minutes, and I thought I killed her. But between my mom with her Bell's palsy, and I thought she had a stroke, and this, I'm like, why? But it worked out okay. So if they're prone to syncope, tell them to eat beforehand, be well hydrated beforehand, numbing beforehand, have music beforehand. Make whatever they need to make that environment comfortable for them is what you should do for them. But if they've syncopized before and they're fainters, and we have people that are fainters, and I remember your story when you were on the surgical rotation and you, poor thing, you were in the OR and as a medical student and you fainted. There are people.
Someone started bleeding out and the blood just started bubbling up and overflowing on the floor. And I was like, I'm done.
And you're like, surgery's not for me. Right, right. And also the warmth of the room and, you know, all. Yes, exactly. And also be careful about lidocaine too, because lidocaine.
Ask you about, do you ever have them do EMLA, the extra sensitive patients, or no?
So we actually do have BLT cream, but you always have. That's why good history and physical is so important, because there was another, you know, litigation. If you're allergic to something like lidocaine and you have a reaction from lidocaine, you're in trouble. But as long as you ask them and they say no known allergies, they check that box, then you're fine, you know. But lidocaine, so I had lidocaine injected in me before, not my face, but from a procedure, and I literally almost fainted and had the ringing in my ears, the bitterness.
Every day as anesthesiologist.
As anesthesiologist, right? So understanding what a reaction is very important. So if the patient starts telling you, I have some tingling in my tongue, a metal taste in my tongue, or I'm hearing my ears are popping, or like I'm starting to feel really woozy, always look at your patient. When they're really, really quiet is when I get concerned, right? And not only am I like taking care of the patient, I always, for some reason, I always also look at the person who's with them, because that's happened too. The person that's with them also faints too. And a lot of times you may not want an extra person in the room because you don't want to be responsible for the other person. But I'm always cognizant of everything that's happening. And if they're not breathing, you don't realize this. When you're getting injected, either you, the injector, is not breathing, or the person's not breathing because they're holding their breath, and you have to say breathe. You have to literally tell them and remind them to breathe, because they'll stop breathing and then they'll faint. So hopefully the patients that you guys are bringing in today are not fainters, because, you know, but then we know how to take care of them. From urologists and some urgent care and ER, I think we're good. We can put a catheter in them and they can take care of everything else.
I
have to intubate
a
someone
young
in this
patient, like a
field.
20-something-year-old, passed out on me in the UDS room. So she's having urodynamics, so just a bladder function test. She vasovagal down and then started seizing.
Yeah.
And my
Yes.
and it, like,
Yes.
maybe it lasted like a minute or two, but it felt like.
Right. You can actually have seizures from the syncopal episode, and they become unresponsive, and it's scary. You know, we actually saw that recently at the Hutch.
Yeah, so my patient, just putting in an IV, it happened, and he didn't have diagnosis of seizures, but
Convulsive sympathy.
yeah. So I mean, of course, I do IVs. I don't think I would use my IV skills in this realm, but you know, I don't think people want an IV when they're getting Botox. But that's kind of an interesting thing I've always thought of. Like, would you want to do an IV in someone who has that history, like a syncopal history?
You
Give them a
can,
liter?
yeah, or just have them like drink plenty of fluids beforehand, tank them up beforehand. I mean, if they're able to do it orally, you know, then that would be best, obviously, because you don't want to make it too invasive. But
And the best thing is, I actually like it when they pass out, because I can finish my procedure. I've done that with lip fillers.
Oh, Lord.
They were so apprehensive, they passed out. I'm like, perfect. While they were out.
No. X that on the thing. Erase.
We have to edit that part.
But you know, something cool, like put a cool towel on them, that type of thing too. And just remember, afterwards they can kind of get nauseated and they can vomit too after that whole vasovagal thing. Okay, so short-term brow ptosis, lid ptosis, what you want to tell them is that it will resolve. It will resolve. All right. And you just keep saying that, you know, at 4 weeks, at 8 weeks, until it resolves, and you're like, see, it resolved. So what do you do for eyelid ptosis? Now, there is something that you can give. It basically raises it about 1 to 2 millimeters, which sometimes is enough. How do you know someone has ptosis? Well, when they're looking at you in a regular neutral gaze, if their lid passes their pupil, or if they're past mid-pupil, then that's ptosis. And you can prescribe this aproclonidine, or iopidine is the brand name, and you tell them to put 1 to 2 drops 3 times a day until it resolves. Don't make sure it doesn't run down their face and get into other areas. You know, you want to always wipe and make sure they just get it into their eyes. That will help contract Mueller's muscles, which will give it that kind of, you know, 1 to 2 millimeter lift. Next
So you
one.
do it for 3 months?
Here's the thing. If they have the ptosis, it usually happens right away. If it happens right away, then you know it's probably going to stay for longer. So you're not going to tell them just a couple of weeks. You may say it may last 3 months. All right? So get them in the mindset. You tell them to do the exercises. You tell them to put the eye drops. And you tell them, you reassure, this is temporary, this is temporary. And that's how you do it. If they get ptosis later on, right, and then you prescribe this and it actually works well, you know that the ptosis is very mild, maybe just a little bit diffused into the levator palpebrae muscle, right? Now, some people have lid ptosis to the point where they can't even open their eyes. Some people have just lid ptosis where, you know, as I'm putting on my eyeshadow, I actually have to lift up my brow. All right, so that's how they'll tell you. Things are a little bit different. Okay.
Not gonna over the counter.
It's not. You have to
They're
call in a
both-
prescription.
Both of them, right?
Yeah,
Okay.
yeah.
Does one work better than the other?
I don't think so. I think they both are the same type of,
Minimally.
yeah.
Both is
Give you-
3 times a day,
Acetylcholinesterase
both of
and-
them? Both of them is 3 times a day?
I believe so.
Okay.
Yeah. Iopidine or aproclonidine is the one that's most, the other thing too, for botulinum toxin, be careful of the lacrimal gland. So somebody was asking me like what other things, some people can actually get dry eyes afterwards, right? So just have to be careful. So if you do brow lift, if you're doing, you know, crow's feet, just tell them you may have some dry eye. So people with like severe dry eyes, you don't want to inject their crow's feet.
So where should I come from?
Right here.
Oh.
Lateral. Right. Yeah. So you don't want to inject the crow's feet area because it can actually diffuse into there. Yeah. All right. Okay. Complications. We'll talk more about that in the filler talk next. Oh, go back one. This is a picture of some ptosis that I want to show you guys. Yeah, there. Okay. So you see how that lid goes past the mid-pupillary line or goes right at the mid-pupillary pupillary line? So, and then this too, very subtle, but you see how this is over the eye, and this is kind of, you know, coming down a little bit. So that's a very subtle ptosis. I mean, true ptosis is if it goes past the mid-pupillary line. So this is just subtle, and this is actually a brow, I think, more of a brow than it is a lid thing, because you can see the brow is dropped a little bit too. So if it's a brow, there are ways to kind of try to counteract it by putting, you know, in the opposing muscle here, right? Maybe a little bit here and a little bit here. But if it's true lid ptosis, there's really nothing you can do because it's in the
And
levator
sometimes
muscle.
people do have underlying ptosis to begin with. That's why the before pictures
Yeah.
are so important.
Yeah.
They
The other thing
match the-
too, people with deep set eyes, hooded eyes, be careful
Yes.
injecting their forehead. You have very, very deep set eyes.
Yes.
And I don't, if we injected you, you know, the brow may come down. I know, you've been injected,
I've been
you're frozen, I'm
I've been
frozen. We need more models than us to inject, right? Every month we get injected.
I know.
I'm giving you my mom's fit, don't worry.
No, you can do your mom.
Yeah,
She'll be
that's
fine.
right.
The team is gonna do my mom's.
Yes.
I think the most important thing is these are guidelines, right?
Mhm.
As you do more and more of it, you'll get more comfortable, and it
Yeah.
just becomes second nature, right? There's no definite recipe for it, and that's where a little bit of the cerebral process comes in. But you'll find that you're a different injector 3 months from now. You're a different injector 6 months from now, and within a year, this is just, you know, second nature. It's like doing what you're doing in your respective. Not difficult to learn, but it does take some time to master.
Mhm. And picking your models is important because your best friends and your family members are going to be your worst patients. They are going to be the crazy patients that are like, I feel this and this
Yeah.
looks weird and
They will,
are you
but-
sure you did this right?
But hopefully your
I will
mom's
not
gonna
inject-
sue you, so it doesn't
I will
matter.
not,
Just
yeah.
inject, load them up. That's your opportunity.
Yeah.
Do every single thing on their face.
Your crazy friend will be your worst your worst patient, so you may not want to inject that person.
Can I
But
just add
anyways,
something really
Yeah.
quick? So just again from clinical experience, at the end of the day, you have to remember you're the clinician. So when I first started, you know, people come in and they have their desires, right? So especially with lips, right? And they want these big juicy lips and, you know, as the clinician, you want to meet their needs, but you need to decide at the end of the day what you feel will look good and what's comfortable. Because I don't want someone walking around looking what I think is very unattractive, saying, "Hey, Dr. Abdul did my lips," and everyone's going, "Oh."
That's
So
excellent point.
just a big
Mhm.
picture, some like especially when we get into fillers and things. At the end of the day, you're the clinician. You meet their needs as best as you can, and then you let them know, like any procedure you're going to do. Hey, you know, this is kind of what I'm willing to do. If they're not okay with that and they want the over,
Let 'em
then
know.
let them go somewhere
Let
else
'em
if you
go.
have to. But I mention that because sometimes, You know, especially when you're starting off, you
Yeah.
just want to make them happy and you want to do it right. Remember that. And another thing I do want to add about facial symmetry. Yes, we're trying to achieve that and balance it. So I do a lot of research about the face and structure and like lines. I love like physics and looking at lines. There's actually more beauty in asymmetry. Not something that's very, very asymmetric, but your goal is not to get it perfectly symmetric.
You will never meet that goal.
Right?
Yeah.
So these are just big picture types of tips that, you know, you make that decision. You ultimately, like any other procedure, you're going to make that decision. You decide, you let them know whatever they feel good about, they stay, and if they don't, they leave. But it's your reputation, and it's also, this is your craft, and this is just like you're an artist, right? This is your style, and you define your style and stick to it.
Especially with lips too, just to piggyback off and then we're done with this talk, is they see Kylie Jenner and they think my lips are going to be like that after one syringe. You have to tell them, I'm going to build your lips because you have no foundation for lip building right now. So the first one is just going to be a little bit. The second one is going to get you to, and so if you're able to do it, if you like doing it, if you're okay with doing the lips, that's what you tell them. Because if you do one syringe full, they're not going to be happy. And what happens is they swell for the first 24, 48 hours, but after 2 weeks, the swelling comes down. They're like, where did my lips go? I want more. If you don't tell them ahead of time and they think they're going to look like Kylie Jenner after one injection, even though their lips look nothing like her, you know, now, they're going to be disappointed. So you have to tell them. You're going to need at least 4 to 5 syringes, I mean, if they really want to look like that. So they have it in their mind, okay, so I'm okay of getting 1 syringe now, coming back for a second one, coming back for a third. So one patient that I have coming today, she wanted thicker lips. But she said to me, I don't want anyone at work to notice. She actually works in a urology office. I don't want anybody at work to notice, and I want it very subtle. Those were her first words to me. And I remember those words, because if you make it big and you make it not subtle, they will be upset. But guess what she said to me the next day? I'm upset because nobody commented on my lips.
She wants both.
So she's like, I'm just a little disappointed. Nobody commented. I don't think people even noticed. And then I showed her before and after, and I said, look how much different it is, you know. And she was like, oh, you're right. So
If you
just
work
so
at a
you know.
dentist's office, maybe.
What do you guys use for, like, is it a special camera that you're using, or just any camera to document the before and after? How do
You can use any camera, any cheap camera on a tripod. You can even use your phone.